we wouldn't have any acute services actually in Buckinghamshire, while Berkshire would have the Thames Valley, the Royal Berks, and then on its outskirts, very close by, would have Friendly Park Hospital in Surrey and Hillingdon, which has already been alluded to. So that's our first concern. The second concern is around the funding, the issue of affordability and the practicality. Funding would come from the sale of the land of the hospital sites, and it assumes substantial development on vacant sites. So that's highly optimistic, given complex planning histories in our patch. So the project would need significant financing, additional funding from either local commissioners or central government, direct government funding. And is that likely to happen in the short term, given the complex and current expenditure plans? Dr. Lee mentioned the PFI. Yes, there are huge questions about the history of them, but the fact is, in Buckinghamshire, we have 3 hospitals, Wycombe, Stoke Mandeville and Amersham, which are PFI projects and still have at least 20 or 30 years to go on them, which means that even if you knock them down, the Thames Valley, the Royal Thames Valley Hospital expenditure in building that, you'd still have to absorb those PFI costs. So that is a huge factor in the business case for the new hospital. We're concerned about the impact on community hospitals and the shift to community services, which is where we see NHS services going for the future. There needs to be much more care in the community and in people's own homes and so forth. Dr. Lee mentioned elective surgery in community hospitals, but the likelihood is that once you have the Royal Thames Valley Hospital, all the elective surgery and specialist care would go to that hospital, and the community hospitals would become less viable, and services would be pulled away from them. We are concerned about the impact on localities generally in our population patch. So Marlow would have the best journey down to that site, but apart from that, most of our patients would face loss of local services, longer journey times, and loss of the local services would, because of the shift, it wouldn't justify the shift of a considerable number of services to the new site. So, in conclusion, so the clinical pressures driving the NHS, there is a lot of common ground between what Dr. Lee says and what we are working on locally and what we understand. Our solution, however, is significantly different. So the local NHS vision for Berkshire is based on a carefully constructed network of acute hospitals with services concentrated to reflect the clinical needs of our population and coordinated across a number of sites so that to ensure that the local population is still served. Yes, undoubtedly that's complex, but we wouldn't want to see towns the size of Wycombe and Aylesbury without a wide range of acute services. So we will have to look at staffing mix, skill mix, new approaches to the ways that services are delivered. But we've done some of that reconfiguration already, and clinicians working together with the patients in mind, we've shown that can work locally. So, thank you.
Thank you, Dr. Lee. May I ask just a couple of questions before Dr. Lee comes in? To Dr. Gannett, please. Yeah. You said that you have lots of common ground with Dr. Lee. May I assume, or can I ask you, do you agree with his presumption that the days of the District General Hospital are dead and that we can't get our services back?
District General Hospitals were built in the 60s and 70s in an era when hospitals were in a different place. And I mean in terms of services provided and so forth. So we have 3 in Buckinghamshire. The 600,000 people are the sort of size of population you need to have the training, the critical mass of the footfall for consultants to keep up their specialities. So the tiny district hospitals are not safe, they're not clinically safe. So I certainly do agree on that. Consolidating services onto fewer sites is very much the way forward, and configurations all around the country are working along those lines. And as I said, that's what the network that we have in between Buckinghamshire and Berkshire.
I suppose my second question follows on from that, and I suppose, who does geography really matter to? I mean, we're talking about, from what Buckinghamshire as a county not having this network, not having any acute services if it goes to Berkshire. Does it matter to the public, or does it matter to the bureaucrats?
What it has is a domino effect that I alluded to. So Buckinghamshire doesn't have any services. So the north of Buckinghamshire, people will need to go to Northampton, Bedfordshire, so forth. South of Buckinghamshire would need to go south to into Berkshire. It's not about the geography, it's about the quality of services and the localness of services, and the drive is very much towards local services. Acute specialist care is what's provided in hospitals, but the reason the days of the district hospital is dead is because when medicine is going with the demographics that we have with the large population and so forth, all medical care doesn't need to be in a building with hospital beds, but you do need the specialist services. You do need to be able to get to people in their homes. You do need community rehabilitation, those sorts of things. So you need buildings for those concentrated locally where people can get to them. Those would not be provided from a super hospital. So geography in a local sense for the needs of the population is important. If you have a super hospital and you lose all your community services, geography matters because you haven't got anything locally.
Okay. Dr. Lee, would you like to?
Yeah, sure. I think we agree on quite a lot there, actually. I think remind me, which, in terms of the area you cover, what's your furthest north practice in the commission group?
Brixton.
And your furthest east? Cheshire?
Furthest east would be Cheshire.
Yeah, and then down south, it is Marlow,
going down Marlow is part of our group, but going our most southerly part is Ivor, and Denham and Burnham.
Okay, yeah. So you're sort of right round south.
Yeah. And I would add that we are the South Bucks Commissioning Group. There is a North Bucks Commissioning Group as well, so their most northerly practice is Buckingham.
Right, okay. And Milton Keynes is separate?
Yes.
Yeah. So Buckinghamshire's geography sort of does matter because it's long and thin. It's got a terrible road transport up and down the spine of it. And so you've got Milton Keynes, Stoke Mandeville, and Wycombe, which are the traditional sort of three DGHs certainly for the last few years. And it's not great because the road between them are really poor. And that's a challenge for Buckinghamshire. As I said before, I mean, if we go through each thing, I mean, a knock-on effect of other hospitals, I've made no secret, of course it was going to have a knock-on effect. I think we've got too many hospitals in this country, full stop. Okay, we've got too many acute hospitals, which by definition means that if we've got too many acute hospitals, some of them won't be existing in the future. That's just the truth of the matter. Now, we have to decide, and I would suggest it's better with a national plan. I keep saying that so that everyone understands that I recognise the weakness of this being in isolation of other hospitals. But if we've got too many acute hospitals, some are going to stop being the hospitals that they have been. That's the political reality. It's got nothing to do with party politics. It's going to happen. And so I would rather that it happened in the most acceptable way. The difficulty is that we have to wed where we are now with where we would ideally like to be in the future. And that's a pretty tough journey to navigate, financially, politically, and I recognise that. But I come back to the same point that if we're going to go down a specialist centre, and I don't like the super hospital because it sounds like that term, it sounds like gobbling up everything. If we're going to go down the specialist centre model, then I think they've got to be on roads that are accessible to a greater number of people. And so there's, which is ideally motorways. So if you're going to go for a specialist care, it's got to be a motorway. And the difficulty that Buckinghamshire has is that there isn't really a motorway that serves the whole of the... There's no motorway that does that. M40 sort of comes across here and then further north up at the Milton Keynes, you've got the M1. So it's a challenge for Buckinghamshire, and I don't dispute that. But the same principle remains that we need to consolidate our services to get better outcomes, clinical outcomes, which is the one thing that I would add to your list, which is I am convinced that if you go to the specialist centre, you get better clinical outcomes. People survive operations, people live longer, your loved ones live longer. This is about better care and better clinical outcomes. It's not, you know, if I thought that this was going to lead to poorer clinical outcomes, I wouldn't be talking to you this evening. The fund, you made reference to my feeble attempt at being a surveyor and a estate agent and a property developer. I mean, there were caveats all over that. I mean, my researcher and I went to try and make some sort of punt at what the value of the property was that was going to be relieved by doing this. In terms of the planning, most of the locations, actually, I suspect, you would probably have some challenges over density of development, but actually I suspect the planning would go through because of where they are. So I think that how much you can release from those sites, if it is of course, particularly in current economic circumstances, is totally up for debate. But I would suggest that the sort of sites that are indicated in the model, there's a significant sum of money there to release. And don't forget, I also didn't talk about administrative property. I hardly touched upon mental health services in this model because it would be the complexity level would increase. With reference to PFIs, as I've said before, you know, wouldn't it be appalling if, because of an appalling set of contracts signed, that you prevented delivering the services that would be better for all, just because of a PFI contract? I would hope that that wouldn't be the only reason that it didn't happen. And finally, local services. In no way did I, you know, and I hope it didn't come over in this idea that this was going to somehow completely take over all of the services and therefore swallow up everything else, suck away community services. I'm totally of the opinion that people shouldn't go to hospital. Okay, the last place you want to be in life is in hospital. You want to be pushing patients away. You want them in the community. You want them in their homes. You don't want them. Okay, so and you want them in community clinics. You want them away from acute emergency hospitals. And so the size of it, we arrived at the size of it purely very simplistic sort of thing. We looked around the country and went, well, what's been done recently? And we sort of fell upon the Norwich Hospital as an example. It doesn't necessarily have to have 1,000 beds. I mean, I'm not sort of wedded to this sort of grandiose project that it has to be to have 1,000 beds. It could have fewer than 1,000 beds. It is more to do with the fact that we want to concentrate emergency and acute surgical medical services onto one site at the most accessible point for a large population. That's the key point. But I would want to retain those community hospitals. I'm a big fan of community hospitals. They provide wonderful care and a wonderful environment. And patients like them, and that's also, you know, part of it. So I wouldn't want it to come over that this is somehow some sort of big gobbling up of all healthcare provision in the area, because that's I wouldn't want to see that.
Thank you very much. I'm conscious of the time now, so can I say if it's okay for it's okay for everybody? Is everyone happy to go on for another 15 minutes and then we'll close?
I haven't eaten, so
all right.
Can we make it?
We'll make it 10. We'll make it 10 more minutes and a couple more questions. And Mrs. Alexander.
Thank you very much. I started my nurse training some, I think it's 58 years ago.
Yes.
I've been interested in hospitals and so on. I've been lucky enough to travel around on the continent and in America,
Yes.
and I have seen some facilities. I think this is a very sensible, thought-out idea. However, I think you've got to to make people understand the advantage of what is now the district hospitals, the local hospitals, and the valuable part they will be playing within the work. This is for the
When you're sick.
the really sick, the people that are in urgent need of urgent care and very highly specialist care. But the run-of-the-mill, the ordinary hospitals, will be able to look after the people for most of the
But they will be smaller as a consequence, madam. That's
Yes.
my point. I mean,
No,
you're right.
But I think you've got to make sure that people don't think they're all going to be closed.
No, I've not. Thank you for pointing out. In fact, the only ones that I've said that I would close are St Mark's, because I thought, well, if you're going to have a hospital in Maidenhead, why retain St Mark? Heatherwood, because this is actually out of date with site. I would have Braggs Bridge here, which is the Royal Berkshire site, which incidentally is not fully staffed or packed with the services because Royal Berks can't afford to do it. They built this building and the second floor is empty. Yet more evidence of the fact that we can't be doing what we're doing. We've got to think cleverly. So I didn't think that with Ascot and Brackley 3 miles apart, I thought you just needed one site. And the same applied in Wexham. I retained this, but obviously Wexham was closing. And so you would diminish the size of the hospitals you have because they'd be offering less services, but they would be offering the care that isn't about when you're acutely unwell or really sick, because that is the way forward. That's actually the whole vision, to be honest.
One more question? Okay, yes, one more question and I'll call it close. One more question? Someone who hasn't asked before. Mr Price, has had his hand up.
Thank you very much, Mr Chairman. I've actually been to every single one of Dr Phillip Lee's presentations, and a little bit more has come out with questions and the rest. I've listened very carefully to what you've said, Dr Gamble. I find it a little bit hard to grasp when you say that there will be very little acute services if this goes ahead in Buckinghamshire, when you know that doctors, and you're the head of the clinical commissioning group, has actually been told, and that's just been confirmed in a letter that has been received from Anne Eden, the CEO of the NHS Trust, is that effectively the vascular services are going to John Radcliffe in Oxford. So what's going to happen then is, I'm sorry, but I see that whilst I live in Marlow, obviously we're just on the bypass, but I've spoken to a lot of people in Wycombe. The gentleman I'm sitting next to he lives in Wycombe, at the other end of the town, and he's looked at all this and he is in favour. There's still a lot of answers to come yet before it becomes a reality, but you must sit and listen, because if you don't, the amount of service that you're going to get here in Wycombe is going to diminish, because the PCT has slowly but surely diminished, and we've been fighting for years. They say, yes, we're listening. They listen, don't take a bloody blind bit of notice. So at this moment in time, I've got a very open mind, as I hope that most of you have, and that is to see how this develops, and to make sure, which, by the way, the changes and the pushing out of services to Stoke Mandeville is, we were promised by the PCT that before things were moved is that they would develop effectively what's being proposed here. in terms of the satellite hospitals to give local service. Hopefully Marlowe's clinic will be developed. I mean, there is room for it to be developed. But the PCT said, yes, we will make sure that these things are put in place before any changes are made. And what have they done? Nothing.
No, I think we're straying
No,
somewhere.
but the point is it is imperative that these satellite hospitals are developed to the extent that care just below this standard of the hub hospital is actually put in place.
Okay, thank you very much. Well, thank you everyone for your
Can I
attendance.
ask one more question of Dr. Lee?
Okay, you have had
Very
your hand up,
quickly,
very
but
quickly,
it's
yes.
very relevant. How do we, as a public, take forward your idea that you want this larger strategic plan? What can we do?
Well, I mean, I sort of looked at this and thought, well, okay, I will put this out. I knew it was going to disrupt, and I knew it was going to challenge, and that was actually part of it almost. I didn't want to see sort of incremental sort of changes that Terry's alluded to, which have happened in other parts of the region. I think we need a grassroots campaign of people knocking on doors and building up a sort of a pressure from below, and you contact the GP syndrome, or you contact the commission group, and you argue the case for this. And my responsibility, I mean, I've taken on quite a lot here, and I've gone around, and as I said, I've got a couple more meetings to go. I will continue to lobby at centre, because ultimately, going back to what you were saying earlier about financing, realistically, even if I could realise all the money that I think you can realise out of these assets, you're going to need central